Morning, everybody. I'm John Towler. I chair the CCG governing body.
Councillor Kevin Rostance, and hello, Kevin. Good to see you.
Good to see you, Sir David. Yes, you're looking good. Yeah, Councillor Kevin Rostance. I'm the chair of Health and Wellbeing Board for Nottinghamshire County Council.
Thank you, Kevin. So we'll go to Alex Ball next.
Morning, everybody. Thanks, David. Hi, Alex Ball. I'm Director of Communications and Engagement for the Integrated Care System.
Thank you. Rebecca Larder.
Morning, I'm Rebecca Larder, ICS Programme Director in attendance at this morning's meeting.
Thank you, Rebecca. Claire Ward.
Good morning, I'm Claire Ward. I'm Vice Chair of Sherwood Forest Hospitals Trust.
Thank you. Jeanette Swan.
Morning, I'm Jeanette Swan, ICS Office Manager.
Thank you. Richard Henderson.
Good morning, Richard Henderson, Chief Executive of East Midlands Ambulance Service.
Thank you. Councillor Tony Harper.
Hello, good morning. Councillor Tony Harper, Chairman of Adult Social Care and Public Health for Nottinghamshire County Council.
Thank you. Eric Morton.
Eric Morton, Chair of Nottingham University Hospitals.
Thank you. Gerald Ellis.
Good morning, Gerald Ellis from PICS. I'm the lead for the acute home visiting service and clinical pharmacy programme manager.
Thank you. Joanna Cooper.
Good morning, everybody. I'm Joanna Cooper. I'm Assistant Director in the ICS team here, taking the minutes for the board.
John McDonald.
I'm John McDonald. I'm Chair of the Sherwood Forest Hospitals NHS Trust.
Andrew Hoare. Thank you, John.
Hi, I'm Andrew Hoare. I'm Interim Lead for Data and Technology for the ICS, seconded from Notts Healthcare.
Thank you. Rosa Waddingham.
Rose Waddingham, Chief Nurse for the Integrated Care System.
Thank you. Tilan Bartholomew.
Apologies for joining late. Good morning, everyone. Tilan Bartholomew, GP and Clinical Lead for Mid-North ICP.
Thank you very much, Tilan. Michael Williams.
Good morning, everyone. Michael Williams, Chair of Nottingham City Care.
Thank you. Kelvin Lim.
I am Kelvin Lim. I'm Medical Director of PICS.
Rosalind Stannard.
Hello, I'm Rosalind Stannard. I'm the Communications and Engagement Manager for PICS.
Okay, thank you. Hugh Porter.
Morning, so a few minutes late. Hugh Porter, GP and Interim Lead for Nottingham City ICP.
Andy Haynes.
Morning, David. Sorry I was late. I'm the ICS Managing Director. The other Chief Execs and Fran Steele, who should be joining us, still on the vaccine call, David. They'll join us shortly.
Okay, thank you. And Eunice Campbell-Clark.
I think that Eunice's audio is still connecting. She's just joined us.
Okay, jolly good. Well, Eunice is from the City Council. Okay, any apologies, Joanna? Can you just...
We do, yes. So we've got apologies from Melanie Brooks, from Jonathan Hart, and I've heard from Tim Hayward. He'll be with us, but he's running late as well.
And Paul, I've not asked you to introduce yourself, and I know you've got to go very shortly to other matters.
Thanks,
Paul
David.
Devlin.
Paul Devlin, and I'm Chair of Nottinghamshire Healthcare.
And Paul Robinson, did I? No. Okay. Would you want to go ahead?
Hello, everyone. I'm Paul Robinson. I'm the Finance Director for the ICS, and I'm also Finance Director at Sherwood Forest Hospital.
Yeah. So for those of you who've chaired large meetings of Zoom and Teams, one of the problems is that people don't sit still, unlike the conventional in-person thing. So the lists move up and down and people move across the room. So whichever way you do it, there's every chance you'll miss somebody. So have I missed anybody else?
David, it's Lynn Bacon from City Care.
Lynn, how could I?
But I won't take it personally.
No, don't.
I'm Chief Executive of City Care and I'm the SRO for People and Culture.
Excellent. Thank you very much. Would anybody like to declare any conflicts of interest for this
I wouldn't, David. It's Adele Williams here. I'd like to declare that I'm here, though. I'm just not able to switch on my camera. I'm Adele Williams, portfolio holder for adults and transport from City Council.
Excellent, Adele. Thank you.
I'm here as well, David.
Yeah, great. Thank you, Eunice. And just to ask if you're not speaking, if it's possible to go on to mute, that's good.
Well,
just in case we get a bit
I'm just trying to get out of this bit here. So I'm hoping.
No, that's fine. Never mind. Oh, thank you, Eunice. So, sorry. Anybody want to declare any conflicts of interest? Okay. The only thing I would, it's not exactly a conflict of interest, but in my role as the chair of the Social Care COVID-19 Task Force for Social Care, I'm heavily involved in the national vaccination programme, and particularly the implementation of the social care elements of the programme. So I just wanted to, I don't think it's a conflict of interest, but it's just an interest from a different perspective. So I just wanted to acknowledge that. Okay, so we then move on to the next item, which is the minutes of the meeting of the 10th of December. And I just wanted to check with you that that those of you who were there record it as an accurate record, and if there are any items arising that aren't on the follow-up action logs, etc., that anybody wants to raise, which you can obviously either put in the chat or in terms of, or if you want to raise your hand, that would be also very good, so that I can just spot that you want to say something. So everybody content with the accuracy of the minutes? I think that's a yes. So then if we go on to the action log, anything arising from the action log that anybody wants to raise? No. My own observation is there are a lot of completed items, which is which is very good, because it shows that we did what we intended to do. So that's to be celebrated. I'm just wondering whether we can sort of archive them, because they're becoming quite a long list. It does show the level of industry, but we probably I think that can be taken as read. So I think that's my own observation. Any other points? No. Okay. So on the next item then, we're going to move on to the patient story, and I'd like to welcome Gerald, Kelvin and Rosalind to talk about the patient story and the paper B that everybody's had attached. So hopefully that's, well, I found it very useful background information, so thank you very much. So if I could hand over to you. Thank you.
Thank you very much, David. I'll try and share my screen with the short presentation that we've got for you. Can everybody see that?
Yes, we can. Thank you.
Good. Okay. So first of all, I want to extend my thanks to the board for the invitation this morning. On behalf of the patients and the GPs of Mid-Nottinghamshire, who the service currently serves, but also for the team that they're out there diligently looking after patients with sort of urgent needs and relieving some of the pressures on GPs today. Particularly at the moment, some of the work that they're doing and the environment they're in is quite isolating. It's very pressurized and stressful. And actually the knowledge that we're presenting today and that we've had recognition from the HSJ award is really quite motivating and helpful to them. So a great big thank you to the board for the invitation today. So I hope that you've all had a chance to review the case study that was forwarded with the papers. This is a typical example of the kind of situation that our team find themselves on a daily basis. John had an urgent need to be seen by a GP. His request was forwarded to our team through our admin call centre. But after registering the call initially, John's condition worsened, and it was felt that it was becoming very urgent. So our team has the ability to escalate the visits they have for the day as they come in. And as a consequence, the practitioner, Darren, was able to attend and see John within an hour of the escalation. So normally we would expect to see patients within 2 to 3 hours, depending upon the caseload and priorities. But Darren was able to make this a priority visit. And really, I think John's quotations here about his experience are very self-explanatory. Somebody who was clearly in pain, very, very worried, the situation very much being exemplified by the concerns of John's wife. And, you know, it's a great story because Darren was able to attend quickly. He was able to assess John's situation. He was able to reassure him, treat him, get a prescription raised, and medications were able to be administered so that day, which relieved his pain and without question saved a visit to A&E. So from John's story, I just want to move on to an overview really of what the service does. So we're providing same-day visits for patients who really are at high risk of A&E and where GPs would normally attend. So the service provides a great deal of support and help for the GPs. But what the service is doing is really taking the primary care service out to the patient. We're not just dealing with the issue that's there. There's a holistic assessment of the patient. Often that results in an onward referral, which could be actually to A&E if that's deemed necessary. Fortunately, the vast majority of the onward referrals are not going to A&E. It could be to involve district nurses or could be to involve the CURT team or other health and social care partners. So since the service was commissioned in April 2019, over 21,000 visits have been made. The levels of onward referrals, 1,500, and we regularly review these. And we estimate that over 5,000 admissions have been prevented in that time. So in terms of the actual team itself, we have 14 highly trained clinicians. They're all independent prescribers. That equates to about 11 whole-time equivalents. So we don't have 14 full-timers, but we have the equivalent of about 11 in our team, and they're supported by 3 admin staff. And one of the important things that we found is that these staff are all permanently employed. When we first took on the service, we did have an element of agency staff, which we needed to mobilize the service as quickly as we could. But actually, we found that was expensive, unreliable, and didn't actually help us in trying to build relationships with general practices and their teams and to become a trusted partner. So the team has carried on through all of the COVID pandemic. They've not been saved from the impact of the pandemic. We've had several members of the team that have gone down with COVID. Our sickness levels as a consequence of the work we've done have gone up, but the team has pressed on. And, you know, I think it's been very much warmly received as a great deal of support to the general practices that we serve. And across Mid-Nots, we're serving 39 practices and a patient list size of over 330,000. The impact of COVID has changed the nature of the visits that we do. Obviously, if the team has to PPE up for the visits, then that slows down the whole process. But we've seen a change in the type of patient that we're seeing. The numbers of respiratory patients that we see have dropped considerably, and there's a more general kind of complex care that we've seen in the past 9 months. In terms of the system as a whole, I think patients really do like the service. I think John's a very good example of this holistic primary care going out to the community. Patients are treated quickly, safely, appropriately, and actually provided the appropriate support if they're needed. In John's case, a district nurse visited him later that day to sort of attend to other aspects of his care. A major part of the service is the trust that we've built with GPs in supporting them, but also in helping them with their resilience. We're in unprecedented times of pressure and stress, and the fact that we've got a team that can help relieve some of that stress is really, really welcome. So typically a practitioner might be doing between 8 and 10 visits a day. And we had an email on Christmas Eve from one of the GPs, just basically saying, thanks for staying open. You know, you've been a godsend, a saviour to us. And one of the other GPs has commented that he feels that the service is one of the best things that's happened to primary care in recent years. We really value the relationship with commissioners. This whole project started as a pilot in Newark as a result of collaboration with the CCG team, ourselves and GPs. We have regular reviews. We report regularly on our activity and our issues. There are daily OPAL reports, and we're constantly looking at ways in which we can review the service, improve the service, and get better value for commissioners from it. In terms of the system benefits, I think appropriate primary care goes out. It's holistic. It's very comprehensive. Secondary care involvement is there when required. We also like to think that we're doing a good job in preventing the avoidable admissions into hospital, but we're linking with other health and social care partners in terms of onward referrals. In terms of the wider NHS system, we do have a piece on the NHS Shared Learning portal, but we've had interest from 9 other trusts and CCGs about the service, about how it works, the outcomes, the costs, the way in which we've implemented it. So we're very keen to look at ways in which we can share the learning that we've got. And I think with that, there's opportunities for other areas to learn from us and to shortcut some of the things that we've had to learn. So in terms of our successes and lessons learned, communications with services, I think, is always of paramount importance. We regularly communicate with all of our key stakeholders. But we can't do this kind of work without the staff who are highly trained and highly committed and who have developed this trusted partnership with their GPs. And the GPs themselves do see the team as an extension of their own practice team. And I think that's a testament to how well the service has done over the last few years. We don't underestimate the importance of the fact that the team can access patient records whilst going to patients and update the records as they see patients and effect particular treatments. We do our best to, given that it's a limited resource, to provide a fair resource across all of the 39 practices. So we share out the visit capability initially on a daily basis. And then if there's unused capacity, we communicate that out to GPs so that they can access that. If one particular GP practice has more need for the service and one less, then we're able to maximize the use of the team. There's clearly, I think, an opportunity, as this is a mid-not service, to expand the service across Nottinghamshire. We would be very interested in working with the ICS board if that was something of interest. We also are constantly looking at ways in which we can build upon the service. And just a final thing, I think is PICS as an organisation is owned by GPs. And we're constantly looking at ways in which we can reinvest into the services that we provide. We're constantly training our individuals. We're constantly looking at the issues that they face. We're looking at ways in which we can make the systems more effective and efficient in terms of communication. We've just introduced a new SAFE app, which helps to safeguard the team. So I think the investment back in the service is a really key part of our values. So I just want to say thank you, and the little lad in the picture is how I felt when we knew that we'd won the award. So over to you, really, if there are any questions for myself, Dr. Lim and Ros.
Thank you very much indeed. And I think it's I just wanted to say I think it's a fantastic piece of work and has been rightly recognised. And it strikes me in a world where there are many ups and downs and challenges, it's very important that we as a system take the opportunity to celebrate such things and congratulate those people who've put heart and soul into making these things work, because they all generally involve people who are willing to go the extra mile, harnessed by good leadership and good system working, which are probably three essential ingredients. So that's my initial observation. But we've got a few minutes from which where we can take some questions or comments. So has anybody got anything they want to ask or say?
David, I think Michael's got his hand up first.
All right, my apologies, Michael.
Yes, a very impressive presentation. I have experience of a similar service in Cornwall, which similarly had great results and was really well supported by local GPs, particularly on that border between Devon and Cornwall, and was a real benefit to Derriford Hospital. I suppose my question is, but the presentation didn't really cover the financial benefits. There are clearly lots of patient benefits, but I wondered if there had been any attempt as part of the evaluation of the project to look at the costs and benefits, because clearly it reduces attendances at A&E and clearly could have financial benefits from that point of view.
Okay, do you want to pick up that one, colleagues?
Yes, thank you, Michael. It's a very good question. I think there's a number of different aspects to the finances of this. I think the big one for us is the savings on the estimated savings really around avoidable admissions to hospital. And I think if we take our estimates alone, and how do you cost something that has not happened? We ask our team to be very kind of careful and diligent about what they consider an estimated avoidable admission. And we've identified that we think it's around 5,000 over the last sort of 18 to 20 months. We think it's around about 200 a month on average. And actually, we might be wrong with that. It might be 100 a month, but actually if it's 100 a month at £3,000 per admission, if we're just talking very broad numbers, then I think that in itself is a pretty powerful argument. But I think the financial side also is the support and resilience to general practitioners, which again, we've costed out the saved GP hours, and we have done some financial analysis, Michael, but I think we're just careful about trying to bang that drum too hard. I think it is very, very important, but it's very difficult to really cost out in a very specific and definitive way because of some of the uncertainties. So I think it's a collection of financial indicators that we believe provides benefit to the system.
Okay, thank you very much. I'm going to take T-Lan and Hugh together before I ask you to respond, Gerald, if that's okay. So T-Lan first and then Hugh Porter.
Thanks, Chair. Just as a GP in Mid-North, just want to echo and want the board to recognize the excellent service which PICS have done. So that's just a first comment. But in terms of the answering the question to which Michael raised is two things which we probably, Gerald, you didn't touch in your presentations. One is the efficiency and the other one is the patient impact on a different way. We look at this. First thing, the way primary care often works is that you get a visit request during the day, and usually GPs tend to do the visits during lunchtime, and this is not a very efficient way. The number of times I've seen in a nursing home you get 3 or 4 GPs from different practices visiting at the same time is clearly not a very efficient way of working. What this service does is that this tends to collate this and an individual to go to one site and actually just efficiencies in every manner of the even being green by not having 4 vehicles driving down to the same nursing home. The second aspect of that is that, as I said, the way how primary care is set up in most practices, in the 40 practices in Mid-North, is that the GPs do visit at lunchtime. So if a patient was poor in the morning, they'll probably have to wait till a bit later on in the day for them to be clinically assessed, which, should their condition deteriorate, could mean another admission. And equally, that other side is that often during the afternoons, if a visit request was done, you'd do a clinical triage, and often a GP would do a visit after they finish the afternoon surgery. This again has a similar sort of knock-on effect, which I said before. So this gives a service which is 9 to 5. We really want this service to be extended so that we can want patients to be seen even later on in the day, because patients do deteriorate in the afternoons. They don't deteriorate at a particular time of the day. And that sort of captures the question which Michael said, is it's sometimes really difficult to quantify what the admission avoidance was. But what we know is that if you spoke to any GP who's used the service, we could probably give you an idea of the sort of savings and the quality aspects of what we've done. So my final comment was, this itself is another way of showing how looking at things differently, because when the project was initially launched, we did have some GPs thinking, saying, look, I know my patient best, so I'd probably be doing the visiting. But once you have a service which kind of crosses those boundaries and moves outside the traditional style of thinking and serves the population, if you ask any Mid-North GP, like us in the presentation, is you would not want to do without this service, and therefore we need to, this is a way of, again, innovative thinking and working differently. So thank you very much.
So T-Land thinks it's a very good idea. I think that's in short. Hugh.
Right, thanks. So first of all, congratulations to Gerald and Kelvin, everybody, for the work on this and getting the award. But makes me reflect. So what you may not be aware is that the City CCG had exactly this same model from 2013 to 2016. I have external evaluations, Michael, with the financial stuff for this. If you wanted to see it, I can show you them. They were done. But we as a system, we decommissioned that in 2016. So I think it's just an interesting thing for us about communication as our system. And an interesting thing of there was maybe some, it's just a classic example of why we need the ICS to function, to sort of share that learning, because we've done this before and we decommissioned it in part of our system, and we reinvented it exactly because the evaluations, do show that it saves, it's good for quality, Michael. It does save the system money, but the financial pressures at that time meant it was decommissioned. So it's just an interesting reflection, and I'm quite happy to share that with Kelvin and everybody, because I've got some interesting evaluations of it. But I think for us as a system, it might be quite useful to sort of think, well, that is a classic example of why we need to get better at working it as a system, because we've gone round in a loop, and we need to think, actually, if we are going to roll it out, what's that learning as well? So just an interesting reflection. When I saw this, I thought, oh, I remember I used to have exactly that same service, and the GPs loved it as well, T-Lan, because it really supported primary care.
Yeah, I think it's quite a salutary lesson, really, Hugh. And was it decommissioned because? So if it was thought to be cost effective and improve quality, was it decommissioned because everything else that was being done was even better quality or better value for money, or was it because people were up against it and they needed to do something, and core services couldn't be other services couldn't be decommissioned for other purposes?
It was primarily about a prioritization process during the sort of financial challenge at the time. So it was value for money, but there were sort of other things were higher priorities.
Sure.
So it was a process doing it, and that's we have to understand the financial envelopes we're working with. It's just quite an interesting bit of learning. So not criticizing that decision.
No,
the decision went through the process, but I think it's salutary. This is why we need to make us work better. This is a whole point of the ICS, isn't it? It's a classic example of why we need ICSs to really work and share our experience and share our history, and then sort of make sure we sort of get things right as a system going forward.
Yeah, and Lynn has said there are several examples where this has happened and we need to learn from this. So I'm going to make a suggestion, and then I'm going to bring you back, Gerald and Kelvin, just for final comments. But I think the suggestion is that obviously the information that Hugh's got is shared with you, and in terms of your ongoing evaluation. And secondly, through the executive team, we ask for the executive team to consider how we can be clear what is going on across the patch in different, whether it be pilots or particular initiatives, and how they can be mapped and understood, and that we are getting the real-time evaluation and analysis on those as part of the overall commissioning planning each year, and the development of the further development of the system control total. So I'm going to suggest that that's the action that arises from that. If anybody disagrees, of course, you're welcome to come in, but I just thought I'd cut to the chase. And then I'd otherwise, and Andy's talked about reflecting the access of this system across access to this across the system in the light of Hugh's comments. So I think that's the other action, Andy. Thank you. That's a very good point. So final words, Gerald, Kelvin.
Thanks very much, Sir David. Yeah, absolutely, Hugh. Well aware of the service that was run in the city. Obviously, there's been a numerous number of projects like this. One of them was up in St. Helens as well. One of the underlying things that I think that ICS has to consider is that when we introduce services like this, and we do have forecasted savings, and we do make savings, you can only make the savings once, but quite often in subsequent years of evaluation of a service, we expect to continue to make savings again and again and again, and that's not possible. When we introduce new services, you often make a service, you make an introduction once, you make a savings once, and because you've introduced that new service, you can't continue to make those savings again and again and again, which has been where a lot of times when we've been re-evaluating services at the end of 3 years, and we've expected them to continue to make a 30% reduction on savings year on year, it's not possible to revert. So that's the first thing. The other thing I would say is I think the service is really, it has been really good. The GPs have liked it, but I think more importantly, the patients have felt supported, especially at the time of COVID, where patients have been really unaware of what they need, what we've had to do, because the information coming out is a little bit jumbled sometimes. I want to pay tribute to the team that have worked with it. And I will get back to Hugh on this, but I think there are slight differences between this service and the one that there was in the city. But looking at a way of expanding the service, I think would be helpful for certainly the whole of Nottinghamshire in terms of being able to evaluate how effective this is, and to help with the strain on our healthcare services in totality.
Thank you. Amanda, apologies, you wanted to chip in. Is there any quick point you want to make?
Yes, thank you. I was just typing actually, but it is an excellent service. We have evaluated it on a few occasions. It looks as if it's probably cost neutral. I think there have been different views across the system in the acutes and versus sort of primary care in terms of how many admissions have been avoided. But it is really excellent. We think probably on balance it's cost neutral. In terms of levelling up across the system, we did briefly look at doing that last year, but I think we need to look at that in the round, because there are other interventions that are happening in other parts of the system that might have some overlap with this. So it needs to be looked at in the round, but I think we should. The other thing to say is having an earlier assessment during the day means that even if people do need to go to hospital, the chances are that they'll have their diagnostics and get turned around the same day without needing an overnight admission. So that's part of the financial evaluation. Thank you.
Thank you, Amanda. I think that doesn't change the summary I gave of the actions that will be taken with Andy. So I think, but it's useful context. Thank you very much indeed. And and thank you to Kelvin and Gerald, much appreciated. So we'll now move on to the COVID-19 response and vaccination programme, and I'm going to ask Andy to make a presentation on this.
John, sorry, David, I'm just going to give a brief verbal update. The slides were circulated with the board pack, David. Sure. The situation in health and care in our system is critical and has been now for a couple of weeks. The peak of beds occupied by COVID is beyond the April peak. So we have between 1 in 3 and 1 in 4 beds occupied by COVID positive patients. The admissions are continuing to rise, and our modelling suggests that that will be the case until early February. So partner organisations are already into their surge plans, and we've taken additional measures to match the expected demand, which starts to become significant and critical from this point to the end of the first week in February. Around beds, around the staffing for those beds, and around critical care beds. So plans have been put in place, but be under no illusions, the situation is difficult. And remember that the shape of our epidemic curve is such that we've been pretty much at very escalated levels now since October, although we had a little bit of respite with a lockdown and Tier 3+ in early December. We've been on this for a while, so the toll on staff is very significant. So it's fitting that we had the presentation from PICS about admission avoidance, and it's fitting that we've got a presentation about health and well-being. The impact on planned care is very significant, and I'm sure Richard and Tracy may want to comment. Clearly, to manage the hospital bed flow, we're having to manage the discharge from hospital and those admission avoidance measures very, very carefully across the whole system. Partners are very engaged with that, including the ambulance service. And therefore, I think we should reflect that the response has been notable. I think going forward, there is, I think, concern about staff. I know that various people have been on the media to express that. In terms of vaccination, I really just wanted to highlight that we're into the first 2 cohorts of care homes and 80+ with a significant push. Considering that the community vaccination sites only receive their vaccine supply in the first week in January, the ramp up in that has been significant, but in order to meet those targets for the end of January and preferably for care homes by the end of this week, it's a huge push, again, involving partners from across the whole system. And so the vaccine programme is ramping up. We have 3 hospital hubs, 6 community facing sites open, 2 more community sites open imminently in the next few days. So I think we are on target for the end of January for the first 2 cohorts and mid-February for the 70+ cohorts and extremely vulnerable. But it is a huge logistical exercise coming at the same time as this critical peak in demand and stress on our system. I think we're going to have a more detailed discussion about the vaccine programme from John later in the programme, David. So I'll leave it there, but invite Richard or Amanda and Tracy to comment in addition if they want to.
Okay, would Richard, Amanda or Tracy want to make any contribution at this stage? Don't feel you have to. Okay, any questions? So we've got, sorry, I've got a hand up here if I can make my cursor move. Richard.
Morning, everyone. Yeah, I just concur with what Andy was saying. So clearly this is a whole system response with health and care and other organisations working effectively together. Just picking up on the point there about the pressure on colleagues. So we all know, I think we touched on this in the last public board, we clearly all recognise that COVID has been in our personal lives and working lives now for 11 months. And what we sense is people are fatigued. I think they're worn out. So we have to be very receptive to that and to continue to do everything possible to support our colleagues across all of our organisations. Because not only are they caring for COVID patients from a health perspective, but in health we still have cancer pathways, we have emergency pathways, and obviously we're all dealing with COVID in our personal life. So I'm sure all of us are extremely grateful for how hard people are working. And the reality, as Andy was describing, we may not have reached the peak yet, and the next month or so is critical for health and care.
Thank you, Richard, and can I congratulate you on your various contributions in the media of this, which I think have been measured, clear, and appropriately balanced, is my observation. So well done. Adele Williams.
Thank you. Yeah, I just wanted to first of all thank everyone for the what must be an incredibly difficult and urgent mobilisation in the current context, and really just to offer. I know colleagues have offered any help we can give as a local authority, whether through our customer hub, through our community protection, to support the vaccination effort. I think it's known that we're frustrated about the lack of data to support our understanding of how many people have had access to the vaccine across the city. Particularly, we're particularly concerned around ease of access to vaccination centres for people who are particularly at risk, or where there might be low take up in that area of the population. I know we'll be picking this up in more detail in a later session, but just really a plea for you to support our ask nationally for more data, more understanding of who has been vaccinated across the city, and particularly in those priority areas such as care homes. So and just to reiterate that offer to do anything we can do to support the effort. Obviously, we're in touch with citizens in lots of ways, and we're using all of our communication channels to support take up of the vaccine. And we've had conversations around that before. But just to put that offer again on the table of any help we can support with in Customer Hub and community protection in particular.
Thank you very much, Adele. I was going to ask Catherine, because Mel has had to give her apologies about the impact, the COVID response around social care and the vaccination issue. So, Catherine, Catherine Underwood, do you have anything to add to that from because obviously care homes are the first cohort and social care workers are in the second cohort alongside healthcare workers and over 80s?
Yes, and thank you very much, David. And I think it's very important for us as the ICS that we hold on to that recognition of the system and the incredibly important work that social care staff have been doing, and our real frontline in care homes of the the day-to-day work supporting extremely vulnerable people, and an area that perhaps doesn't get the same light shone on it always, and it's important that we're able to do that between us and to thank those staff. I think it's fair to say making sure that we have those vaccinations to the care homes is something which we are very much committed to nationally and locally, but it can be a struggle. So I'm very pleased that we've been doing some local work to make sure that between now and the target deadline later this week, we have the coverage to make sure that vaccinations are with that really critically important group in our residential care homes. I would welcome that assurance that we have that plan and that we're confident that that's going to be able to roll out and be successful. And then I'm conscious of the work that we're doing now as a local system, working together to reach out across the much wider health and care system beyond our residential homes into all of those workers who, whether they work for statutory services or whether they work across that whole range, to get the vaccinations that they need as phase 2. But I think my main urge today would be for us to be confident that that first tranche of care homes have got robust coverage across our patch.
Thank you very much. And there are some contributions in the chat on that's in response to some of your points, Catherine, around there is a plan, but I think we can pick this up in our later discussion, actually. So, but I thought it was, I think that was you know, a good overview of the position. So, thank you to Andy. I don't think I've got any more hands up. I'll just double check, and I think I've reviewed the comments in the chat, so I think we're okay to proceed. But thank you, Andy. So the next item is the Clinical Services Strategy Update, which is with Tracy Taylor and Nicole Atkinson, and you've had a range of papers in C papers which to draw your attention to. So Tracy and Nicole, welcome, and please help us with this item.
Thanks, David. If I give an overview, I can then hand over to Nicole because she will know a lot more of the details. So I think the paper is self-explanatory around what the clinical services strategy has been undertaken over the last couple of years, and identifies the waves 3 and 4 that will be completed by the end of April. What you'll also see, and apologies for the number of pages in this attachment, but I think it's testament to the amount of work that's gone on in the wave 2 priority areas. The board will recognise that it signed off the wave 1 outputs last year, or maybe the year before, and those are now into the ICS strategic and priority planning process that the board agreed last month. And what we'll be looking to do is to move the wave 2 outputs into that as well, following hopefully the approval of that today. The board will also recognise that a huge amount of work has gone into these that has been from our clinicians, and the multi-professional input into the development of these service areas has been phenomenal, and there has been a real appetite to continue that input even through last year, when we were going through quite significant challenges in relation to the pandemic. What we're hoping is that the board will allow some of those key clinicians to come and share their thoughts around these models on wave 2 with the board through some development sessions over the next few months. But today it's about approving those to go through the priority process, the recommendations in the transformation of the areas into the prioritised planning process, and securing the work to go forward to complete wave 3 and 4. Nicole, do you want to add? I'm sure there is things you want to add with that.
Yeah, I suppose the first thing to say, as Tracy said, there's been over 1,500 colleagues across our system that have taken part in the work today, and that isn't just health colleagues, that's social care colleagues, that's local authority colleagues, as well as patients and the public. So it has been an enormous undertaking. That said, there are a number of pieces of work that we have shared over time. Firstly, the overarching strategy, which sort of underpins the service review work, and then, as Tracy said, the first wave that we managed to get to the board a little while ago. The reason why we're trying to get these through sort of fairly quickly is that the programme itself comes to an end in April, and there are a number of reviews that are building up behind the scenes. So today we're really bringing to you eye health, skin health, I think diabetes and women's health, really just for you to see what the reviews look like. They have been through our CEG, CRG, they've also been scrutinised through our programme board and felt to be the direction of travel that we want to see our system going in. The wave 3 reviews are about to be completed, and hopefully we can share them with you at a later date. And there are 3 more reviews that will be completed by April. Interestingly, we've managed to get a few mental health ones of those in the next few reviews, and I think that's a really good sign that we are starting to join the dots up. The other thing to say is that there is a significant amount of work that runs through these reviews that really starts to look at the prevention agenda. So again, this isn't just about service delivery in the way that we might have seen it before. I think for a lot of people, they'll be asking the so what question. So we've done all of this work, we've got all of this information, so what are we going to do about it? The first reviews did actually form part of our 5-year long-term plan, so that was built in already. There's been quite a bit of water under the bridge since we wrote that, and things are obviously changing. And so the plan is to incorporate this work into our sort of planning for next year, our strategic prioritisation, and hopefully we can describe that more in the confidential section with the paper that describes that. But it was just really to give people a sight of where we're at, what the plans are for the next few months, and to start to get people to sort of see that golden thread through from this work coming out and also the work that's happening in planning and prioritisation.
Thank you very much, Tracy and Nicole. I'm going to bring in Michael Williams.
You know, this is a really impressive and complex piece of work when you look at it. I suppose the question that I have, one of the factors which is emerging just in relation to general principles around decision making in governance and so on is local by default. And I wonder to what extent, as part of the clinical strategy, that sort of principle is being enunciated. You know, is it emerging as being a real issue? Because in terms of developing the whole complex of place, that sort of subsidiarity, if you like, devolution of decision making, dealing with our patients at the lowest level possible within the system, is clearly quite important. Is that emerging as a key factor in the clinical strategy?
So if I come in, Michael, so I think yes, as you describe it. So originally the initial strategy talked about developing a place-based approach to this. So if you actually start to interrogate the service reviews, what it will describe is, as we start to talk about what we want to see, say with diabetes, for example, what you'll see is at a neighbourhood, what we might see, look to be seeing at a neighbourhood level, what we might be wanting to see at a sort of more aggregated level. Now the how, as in how that group of partners then would choose to deliver that, I think that would be up to, for example, a place to describe. But actually, this is just talking about, as a system, what we would want to see. And a lot of this is about consistency, this is about best practice, this is about education, training, putting prevention at the forefront of what we do, and then really sort of articulating what we would expect to see at those levels of the system. So hopefully that comes through when you look at all of the reviews.
Thank you very much. So just going back to Adele, did you want to come in? Adele?
No, sorry, that's a legacy hand.
That's a legacy
sorry.
hand, no problem. John McDonald?
So, thanks, David. I mean, a huge amount of work, and also we had at the Sherwood board, Amanda came in with Alison Wynne came and presented the overarching wider strategy. Just 3 or 4 points, really. I think the first thing is, although I know we've got a process for approving clinical strategies, I'm not sure whether the board are expected to approve those or whether it's coming for information. Because if it's, and I'm more than happy that some of this detail is scrutinised elsewhere, and the board, if you like, does no more than ratify. But I think it'd be helpful to have a sort of shorter set of papers which said, actually, you know, what's going to change, what are the benefits, what are the risks? Because that seems to me where the board should be coming from on this. We do need to understand the models, but actually we should be focusing on the outcomes and the risks, I think, and that would be personally helpful. And then just a couple of things on process. Do we have, or are we putting together a process for looking at what all this means in activity, capacity and workforce? Because there are some implications, not just from the individual strategies, but when we add them together. And my concern is that we might end up having 20 brilliant strategies which have had huge amount of input, but when we add them all together, the cumulative impact in terms of, for instance, capacity in out of hospital to shift work in, etc., is more significant than we realise. And with the number of strategies we've got, we must be getting close to the time to be able to start some of that thinking. So I'm just wondering whether how close we are on that. Also, I think it's a slightly sort of funny phrase, but I can see all the petals being painted really well. I'm still not quite sure what sort of flower we're going to end up with. And I think that's the point about trying to sort of do the cumulative bit. And the final thing, and this came up at the board, is I think what's really important is as we develop these further, and we've now got a quantum of them, to do some work about what the critical pathway, what investments, disinvestments, and changes are needed across the system for these. Because again, it's quite a huge amount of work, but I'm still having slight problems getting my arms around, and I understand that can only be done when we've got a bulk of strategy work done. But I feel that the really good work on the strategy is almost bringing us to that place. So I don't know if that's helpful or not, but I'm just trying to look forward about how the board deals with this. Thanks.
Yeah, thank you, John. I'm going to take John Towler first, if you don't mind, Tracy, and then we can wrap the whole thing up, if that's okay. John?
Thanks, David. I think I'm going to echo actually some of what John McDonald said. If you read through the detail, it does feel hugely impressive, and the amount of people that have come together to put these strategies together is tremendous. But I guess I just want to check my understanding really, as we're in public session. If you read through the detail, the word funding appears on a number of occasions, but it isn't quantified, and it doesn't explicitly say, and that funding has support from commissioners and other partners across the system. So I guess we shouldn't be assuming today that we can implement any of these strategies successfully. So it kind of comes back to John's question of it's the what next. How do we get from something that's a great desktop exercise on what best practice would look like into something we are confident as a board we can implement and hold ourselves to account for?
Thank you very much, John. And John, Tracy.
Thanks, John. That's really helpful. Both comments are really helpful. So if I go to the governance thing, John, I think you're absolutely right. And I think one of the things that we may want to agree here now is that we have the sort of the brief overview at the next time. I think this board has evolved, and the direction for the clinical services strategy initially was that these would be brought in this way to the board. We're more than happy to go back and re-look at that if the board is happy. So that's the first thing around the governance. You're absolutely right about the detail of them and the breadth, and John's mentioned the funding. All that will happen now with these reviews is that they will form the basis of a prioritisation process within the system planning and prioritisation sort of commissioning approach that we've agreed. So, John, it's not necessarily meaning that we will have funding for these. It may be that the transformation will deliver efficiencies that allow these to be done in a different way. What we normally do when we do system planning is we decide what we want to do, and then we have to go away and get all this work done in that process. We've done it the other way around. We've now got a suite of reviews that have had a broad and wide input from across the system to inform our commissioning intentions going forward. So there's nothing that's going to say we're absolutely going to do that or we're absolutely going to do this. This is about these themes now informing which ones we prioritise, how we do it. And John, in terms of the wider sort of redesigning services for Nottinghamshire, it will then create that picture, join up the dots to make sure that what we can create is what is the future of Nottinghamshire delivery model going to look like, and how will these reviews inform the detail of any of the prioritisation areas. So that's really what these reviews will do. It's not about approving them to say, yes, everything that says in the iHealth theme is going to happen. It's saying, yes, we can now approve these to move through to that prioritisation and commissioning process. The commissioning process will then take that, and do whatever is the right thing to do with them. But actually, if we can agree that the wave 3 and 4 ones don't come like this, and agree what the board would like to see, that would be really helpful, because we're just complying with the very original request that was made of the programme.
And hopefully, John and John, the presentation that's coming from the cell, from the DOFs and from the clinical exec group that talks about planning and strategic prioritisation will start to get under the skin of some of what you're asking. So I know in an ideal world, the two would have followed sort of nicely along, but because they're in different sort of sections of the meeting, that's why it feels a little bit out of kilter.
Okay, thank you. So I'd just like to, Catherine Underwood.
Thanks, David. Just I think this, it's really welcome, really detailed work, and I think in terms of thinking about where we might bring that together, I'd welcome us considering where the opportunity might be for us to think between us about that added value of working as a wider system in relation to some of the very specifically clinical areas. And I know, there's some good, real strong pointers about prevention and about wider, tackling wider issues that enable people with in particular conditions. But I wonder whether there's something that we could consider as a group as these come together, where we might have that conversation about the added value of working, for example, with, in local authority, or that's local authority work, the work in communities. And obviously some of that will play out very strongly at ICP level, but I'd welcome us thinking about whether there's a conversation we pitch at the right time with a cluster of these strategies at ICS level as well.
Okay, thank you very much. So I think what I want to do is just summarise where I think this has taken us to. So the point that Michael made was about considering the sort of local by default issue. So there's a conundrum here, because we've also had some comments about earlier about consistency across the system and the degree to which we're joined up. So but nevertheless the principle of that, I think I'll leave colleagues to take away and think about how that is deployed. And then the comments from John and the two Johns about I think it's about system planning, really. So it's about the resources, the capacity, the funding, and the implementation of this, but also checking rechecking the affordability, the resources, and the capacity in order to do that. And then there are a set of questions about accessibility and understanding. So John McDee's rather prosaic point about the petals, which was wonderful poetry, John. So I think that's covered in the points that people have made. I think Tracy and Nicole have made about future specified time for this involving the clinicians, so that people go underneath it. And one of the things that I think it demands of the board is if we setting up a time and making it a priority to be there to get underneath it, I think is going to be quite important in that. But at the same time, having the shorter reports, which actually following that piece of system work about how this fits together, that pulls out the key ingredients in terms of the performance, quality, financial, and service impacts with the capacity and resources in order to make these things happen. So I think when we go back to the paper actually suggests three things. Note the progress with the development of the ICS clinical and community services strategy, which I think we're doing. A future date to receive presentation of the reviews from the clinical and care professional steering groups that undertook the work. So I think that's quite consistent with what people have said. And then I just want to, in a second, just check whether this conversation affects the release of the Wave 2 strategies through organisations, given the other things people have said about, well, perhaps we need to make sure that these things are joined up. So I just want to check that in a second. But I think we've also got an action for the exec team with the strategy to do the work on the funding, key implications, workforce capacity, and the process for joining that up with other strategies, the points that both Johns have made. So I think those are the key implications. So I think there might be a fourth bullet agreement around that work for the executive team to bring those elements together, those last things that I said. But I just want to check with Tracy Nicole, does this affect Wave 2 strategies rollout or not?
That's what we're asking, John. Basically, the agreement originally was that the board needed to approve these before we moved them on. What we're asking for is for the board to say, yes, they're happy for these now to go into the ICS system planning process. All the organisations that have been involved will have sight of them, but actually it will be the commissioning framework that we agreed at the last board that will now take them and do what they need. And so what you're suggesting will happen in that process.
Okay, fine. Okay, so I think we've between these two, what I said and what Tracy's just said, I think we've covered that hopefully sufficiently clearly for the notes. But can I just thank you, Tracy and Nicole, and if you could pass on our gratitude to colleagues who've worked on this, we would be very grateful. So thank you for that. So now we want to move on, and I'll just get back to the agenda. So the People and Culture Board overview of staff wellbeing. Lynn, we're slightly up against the buffers on timing. So, but please do proceed.
Okay, we will proceed. Can I just welcome Claire Teeney and introduce Claire, who is the Director of People and Culture for both Notts Healthcare and Sherwood Forest. I can't see you, Claire.
I'm here, I think. Can people hear me?
Thanks, Claire.
We can. Welcome, Claire.
So, well, we've got a presentation that we'll run through. I'm conscious of time. It is a big topic. I've heard staff wellbeing mentioned 5 times already in the meeting, which is really encouraging. I think the core message, just before we go into the presentation, is that whilst organisations hold the responsibility for the safety and the well-being of their staff, that there is a system responsibility, and that is very clear in the NHS People Plan. It is also clear through the Adult Social Care Winter Plan, and also through the operational priorities that were sent out to systems on the 23rd of December from NHSEI. So it is a system issue, and that's what we want to focus on. And I have to say that whilst it's a priority for 2021 and a focus over winter, it can't be. It has to be a long-term plan. We don't know what the long-term impact of the pressures will be on our collective workforce. We really don't know that, so it needs to continue. So on that, I'm going to hand over to Claire to run through the presentation, not going through every single slide. And then if at the end I can just ask a few things from the board.
Okay, so I think that's very helpful. Thank you. And I think this is a hugely important topic, and I'm conscious that even with the allotted 10 minutes, we probably wouldn't have done it justice. So I think the key thing, Claire and Lynn, is what we want, what we need the board to do, and there might need to be a wider, bigger impact on this. And we talked about the clinical services strategy. Everything that we do is dependent on the people, pretty much, as well as the money. So anyway, I'll just make that point. Yeah.
Well, what we could do, David, if it's helpful, because we are going to have a big focus on people at the next board meeting, is that we share the slides with the board.
Yeah.
I think the key thing is that it is about the board understanding the responsibility collectively on this. I think it's about recognising there is a huge amount of work that is happening, that it's an ongoing assurance that is required through this board. NHS organisations will have their wellbeing guardians on their board, and they're going to most likely be non-executives. I suspect that all organisations here will have some form of lead role on their boards with this agenda. And I think the key thing from the board is that what we'd like to do is to have a whole system. We focus on figures, how we measure the impact of our interventions, predominantly through the lens of NHS trusts. We want as a system for that to be incredibly broad and have a single method of looking at the interventions, and collectively, where do we share them more? How do we measure what we do where we can? And also that really an ask of the board, that the board considers having a non-executive champion who will help us to coordinate through the leads in the organisations, help support with this work through our governance, through the HR and OD collaborative, to really make sure that we're aligning, we're sharing, we're having a much more system-wide response, and therefore supporting organisations to continue to do the fantastic job that they have been doing, and that we make a commitment that we keep it as a priority over the longer term rather than just winter. Sorry, Claire.
So what you're, I'll bring Claire in a minute. So what you're suggesting is that the slides could be shared, but what I've heard you say is that your specific proposal is that there is a raft of work on this, and there will be a more dedicated item at the next board, is what I think I heard you say, and which probably we ought to allocate a bit more time to. And then the other bit is the non-exec champion idea, which would obviously go for all organisations, local authorities and health organisations. Have I heard that correctly, Lynn?
You've heard it correctly. It would be a real shame because Claire's waited very patiently.
No. I'm going to ask her. I'm going to ask her to come in. I'm going to ask her to come in and add to that. I want to just play back to you what you said and check that I've got that right. So Claire, do add colour to that if you want to and can.
Thank you. Thanks. Good morning, everybody. Nice to see so many familiar faces. And for people that haven't met me, as Lynn said, I'm the Director of People at both Sherwood Forest and Nottinghamshire Healthcare, and I chair the HR and OD collaborative, which is reports into the System, People and Culture Board, and brings together a lot of the workforce leads from across Nottinghamshire to work on joint programmes of work. A couple of things just to highlight, really. So there is a presentation pack that's got quite a lot of detail in it. I would ask that people, if they've got the time, do have a look, because there is quite a lot of information in there. Just to put a bit of a caveat around some of the detail, you'll see in the slides that there's reference quite often to the 3 NHS provider trust organisations. The reason that that data is in there is because that actually, as a system, that data is looked at regionally as an indicator as to where we are on a lot of our workforce performance KPIs. So that's not to say that the health and wellbeing work solely fits within those organisations. We do that collaboratively with all organisations in the ICS, but measuring the workforce data and KPIs in those NHS provider organisations is easier to do, and it gives us a bit of a proxy indicator around some of the workforce issues and things that we might need to focus on across the system. So I just want to caveat that when you look at the pack. A few things to highlight. So as Lynn has said, as part of the National People Plan, there is a focus on health and wellbeing and some priorities for us as a system to work out on. However, as a system, we'd already identified that we needed to focus on supporting the health and wellbeing of our workforce collectively. And during the pandemic, we have done some of that work together. So we've done some collective work to ensure that all organisations and all of our workforce have got access to some level of health and wellbeing support. And that ranges from a welfare approach around people having access, for example, to 24/7 counselling and occupational health support and peer support, right through to, in some circumstances, rapid access to specialist mental health services for people who may be experiencing acute mental health distress. And I think what the pandemic has enabled to do is be able to execute some of those programmes quite quickly. And we've seen the benefits of that and have been able to work together to offer those services to colleagues. We've done some other work around extending health and wellbeing offers into care homes to support staff working in care homes who in those individual homes might not have the infrastructure around them to put in some of the specialist interventions and welfare support that other organisations can do. So the pandemic has also enabled us to come together around the table to do that and do that quickly, which I think is important. Couple of final points from me. We did quite a lot of work around risk assessments, and there was an expectation that all staff were offered risk assessments. I think what that did do was show how responsive we can be. What it also showed is that actually some of the things that we should have in place across organisations and for our workforce weren't there. And so I think there's some work for us to do on that. And I think the other thing that it's highlighted is that we would benefit from doing some pieces of work to make sure that we've got more robust occupational health services across the system. I think that those services are fragile. It's a specialty that's fragile, and it's a specialty that is increasingly experiencing increased demand. And I think in terms of supporting our workforce properly, it highlights to me how it's a good example of how we come together. Actually, we can get more bang for our buck, really, in terms of the offers that we can make available to people. The final thing for me to highlight, which is in the pack, is about the Resilience Hub, the Health and Wellbeing Resilience Hub. So we've had some external funding, I think 200,000, to set up a system-wide resilience hub for health and care colleagues. We only received that investment very recently, so it is early days. And it comes on the back of a pilot that was set up in Manchester on the back of the Manchester bombings. So they set up a resilience hub within the city for citizens to be able to get advice and be referred on to, where appropriate, other services. And that idea is now being piloted in different regions. And in Nottinghamshire, we've received some investment to set up that hub. And that's work that we've just started, and we'll be looking to report to the ICS board on, and receive hopefully your support in terms of helping us evaluate what that looks like and how we can appropriately set up that service so it benefits all of our colleagues across the system. I'll stop there. Thanks.
Thank you, Lynn and Claire. That was really very helpful and succinct but clear and useful pointers for future things. So I'm willing to take a couple of quick comments if anybody's got any, but two observations really. One is that you've set out that agree that there will be a more detailed workforce review at the February board meeting, and this is to highlight, if you like, some of the key issues currently. My second observation is that I think the work that you've led, Lynn, on workforce since the STP days has been terrific in terms of its inclusivity across all organisations and the whole system. In relation to the points you raised, Claire, there's a national people plan for the NHS, but there isn't for local government and social care. And some of the things that you pointed to apply to health and social care. Some don't automatically unless we make them, and therefore thinking about each of those initiatives. For example, occupational health came back as a great gap in the provider land of social care in the COVID-19 task force that I chaired, because there is hardly any. So there's some thinking about how and we did make some recommendations about it. So there's thinking about how that translates to different constituent organisations in formulating the overall strategy. But I have no doubt, because I've known it a long time, about the inclusivity of the approach and the way that you demonstrate. I'm just being vigilant here. And Catherine's smiling. So I'll just make that point. And then the other point is, Catherine wants to come in actually. So.
Well, and David, thank you for your vigilance. I think I was in that theme of really welcoming the recognition as a system for us to understand the diversity of the organisations, particularly in the social care world, but not limited, that we rely on. And so the infrastructures that those of us in big organisations can take for granted aren't available. And I'm delighted to hear about the potential for a hub, and for us to think about how do we as a system really support the workforce, because we know that that's where the magic happens, and for us to really make a difference, to think into that whole system, particularly supporting those smaller social care providers, is just excellent. So I welcome that, colleagues. Thank you.
Okay, so
I know we need to move on, but I just think one of the other areas is around primary care. These are the discussions that we're having around support for primary care.
Yeah, sure.
And how we can link as much as we can. The ideal would be we'd have a single offer that would be across the system. And you are right, David, there isn't the same nationally, but we do keep lobbying. And I think if we have that commitment as a system that we're going to try, but it needs effort and it needs information to do it well, that we try and have it as inclusive ongoing as much as we can.
Yeah, I didn't doubt for 1 minute you'd say that, Lynn, and that's why you're so good at this. So thank you. And so the other thing that you mentioned, the specific thing, was about the non-exec champion. And I think what I suggest we do about that, rather than put people on the spot at this moment, is give people time to think about that and to come back to it at the next board meeting, if that's okay, because there's been a wider review, so people can then, think about and also I think a little bit of a spelling out what the kind of key expectations of such a role would be also helpful, so people know what they're signing up to. So with that, but this is advance notice. But other than that, I'm going to thank you both very much for your presentation, which I've, even though we didn't get your slides, I found it very interesting, and you were encouraging people to look at those. So that's sort of homework for the next meeting, I think. So thank you very much indeed. So we're now going to move on to ICP updates, and if I can ask for quick contributions from John Bruin, Richard Mitchell and Hugh Porter in that order. So John?
Yeah, morning everybody. Hopefully you can hear me. Great presentation from Lynn and Claire, thank you. Very briefly, South Nottinghamshire ICP continues to meet. We've got a board meeting this afternoon, which Nicole has kindly agreed to half chair for me, vaccinations pending. We've agreed the priorities, which are fully aligned to the clinical service strategy, frailty, social inclusion, care navigation, mental health integration, social prescribing. We're putting in some charity bids for some additional Captain Tom monies to the tune of about £500,000, with a focus on looking at things like isolation, loneliness and digital exclusion. We contributed to the consultation on the future of ICSs for NHSEI and submitted that. And a lot of people are working hard in the world of the pandemic and providing vaccines. So short and sweet, David, thank you.
Okay, thank you. And Richard?
Hi all again. Yeah, very similar to John's update. So Mid-Nots ICP continues to meet in public. We've got our 10 key objectives for this year that we're making progress on, that span health and care. Clearly, as John was describing, a big focus of the ICPs at the moment is delivery of the COVID vaccine, and conversations have begun about where we want to take the ICP from April going forwards, obviously whilst delivering on the mandate of the ICS and the CCG. So I'll leave it there.
Thank you, Richard. And Hugh?
Thanks everybody. To a couple of things, much like Richard and John, yes, we're obviously continuing to sort of meet and support the system. So we have one of our sort of key projects is around sort of developing ICP and PCNs. We have a PCN development sort of plan over the next 2 or 3 years. And as Catherine will know, we've started some sort of fairly serious conversations with the local authority in terms of the value of aligning some of the neighbourhood work the local authority is doing with the PCNs when we to drive that wider determinant sort of conversations that we're so focused on, actually such an influence. I think that's a real positive side of things. We started to sort of move towards plans of programme budget for our rough sleepers, looking at a lead provider model for that, and we're also putting in some expression of interest for the Changing Futures programme, which some of you may have heard of, which is would build on the Opportunity Nottingham work for the severe multiple disadvantaged groups. That's quite an exciting sort of ICP development. And then thinking about the sort of workforce thing, going back to the sort of thing we've had from Lynn, we've launched our first tranche of co-mentoring. So this is different organisations, people from different organisations co-mentoring each other to start to learn about different ourselves as a partnership. And Catherine's very kindly leading our second share and learning webinar. So we're doing brief bite-sized share and learning webinars for sort of frontline stuff, just to learn about the different organisations and the partnerships, and you can dip into for half an hour at lunchtime just to understand our worlds a bit differently, because one of the things we found is that actually we know surprisingly little about each other, even though we know we've been working with each other for years. Like John said, we're doing some work with Captain Tom Money. Our focus is particularly around sort of Black and Asian minority ethnic communities and how they've been disproportionately affected by COVID and how we can support them. And last month, I think there was mention about the green social prescribing. That's an ICS thing, but predominantly focused in the city. And we're starting to mobilise that. We had a useful meeting about it yesterday. And again, particularly relevant because a lot of the focus of that is on the supporting people who've been sort of struggling with mental health effects through the COVID pandemic from that side of things. So I'll leave it there and happy to take any questions. Thank you.
Thank you very much, all three of you. That was a kind of a flavour really of current initiatives and development. I don't have any people with any particular questions, I don't think, on my list. So so I think we will move on unless somebody wants to quickly.
I was going to say, John, at some point it would be more, I'm sure, for like John and Richard, sure at some point we'd be more than happy to come back and have a sort of perhaps longer discussion where
Sure.
ICPs are going. It might be useful for us to think about at some point.
I absolutely think that's very pertinent and timely, actually. So this is an update, but that's not quite the same as a systematic sort of accountability, interrogation, stroke support, in equal measure. But I think that would be, and you've got resounding agrees, Hugh, in the chat, so that's a massive affirmation for your suggestion, Hugh. So that's good. Okay, thank you very much, everybody, and I'm going to go back to Andy for the date item.
So I'll try and bring this to resolve quickly, David. I think we've got Andrew Hoare who's joined us. So this was an action board asked us to do. So we approved the strategy back in October, I think, and this is the actual implementation plan. It's been through date board. It's been through all the heads of IT. It's been through a discussion with the finance directors and finance leads. And this was the implementation plan. So today was meant to be highlighting, these are the things we had on the stocks for 21-22. This is what we've committed funding for within organisational planning. Here's some of the extra money we might get from national and other bodies, and therefore there's this gap. So I think that's what Andrew was planning to do, and I'll ask him to be brief in giving that summary. But I have had a conversation with Paul Robinson, because I think in the context of some of the early discussions, we may have to kick the wheels here on the assumptions about some of those investments that we were already thinking about making for 21-22, and therefore I think this will go into that wider round of planning that we discussed earlier. So Andrew, could I ask you just to give us a quick oversight of what you wanted to bring today?
Yeah. Do you want me to show the PowerPoint, Andy?
I think the slides have been circulated, Andrew, so I think the key summary points, as Claire did, would be helpful.
Okay, so the plan would suggest that there are 5 main initiatives, and in the middle of the presentation, there is something that actually looks like the petals of a flower, going back to John's comments. So some of those elements of the flower exist. Perhaps our main thing that exists is at the center of the petal is our data platform, which we've agreed to use GPRCC for. And all of the other petals around the side are in the process of being approved, with the exception of the public-facing digital services, which has become of particular relevance during the COVID period, where many people have taken advantage of using the NHS app to quickly order repeat prescriptions in a way that they were unable to do generally before. We've considered a number of funding scenarios. It is that time of the year where nationally large amounts of money are moved from the centre at short notice into the health service. So as recently as December, we received £2.65 million under the banner of Health Service-Led Investment, or HSLI, which is primarily geared at provider digitisation. The other thing to mention is that, and you will have heard this before, that these investments are fundamental to implementing other strategies like the clinical services and systems strategy, where the transformation that's required can't happen without these initiatives, and also that many of them are interconnected. And so by failing to invest in digitisation of our providers, that would more as a result, and our analytics capability would also be diluted. So by choosing the wrong things to prioritise, we perhaps affect things that are not immediately under consideration at the time. As Andy has said, the date board has studied this carefully. It's been to the finance directors. We made a set of assumptions based on previous experience of national funding. Our system has received around £5 million a year for the last 3 years. So that forms our base case, and we've attempted a worst case and a best case upon that, hence the range of numbers that you see. So just like the clinical systems and services strategy, this is now ready to go into the planning and priorities guidance phase.
Okay, thank you very much. Thank you very much. And so on this, the board is asked to note the progress on implementing the date initiatives, receive the draft strategy implementation plan, and note the unidentified funding requirement and next steps. So clearly there is, along with some other items, that bit of understanding the resource and capacity implications and working through the executive to come up with formula which aligns with other initiatives to make sure that we make progress on this. But I would observe that I spotted the petal, Andrew, thank you, and I think we have done quite a bit in this space that is exemplary compared with other systems up and down the country, and certainly in the region. Secondly, that every piece of evidence I've ever studied about what makes an integrated system work is the critical place of data and information and sharing and utilising systems in order to make sure that that is in place, both to drive the things like population health management, drive responsiveness of services to people's needs, and also for planning and accountability purposes. So all of that is, it strikes me as critical. So this is, I would observe this is a very important part of the architecture. And of course, typically people are variable in their interest in these things, but I think it's terribly important. So other than that, I'm going to go back to Andy and say, is there anything else you need us to do, or anything you want to say?
No, I think the point about it'll need to go into the planning process is the key one. So it's very much like the CSS. This is for board to agree to go into that process now. I don't know if Paul Robinson's got any comments he wants to add now. Maybe they'll come up in the discussion later. But
or has got any money indeed.
Highly unlikely.
Yeah, on that, understand that this needs to go into the planning process, and the FD group has had good sight of the paper as it's been being developed. We remain agreeable to the assumptions that have been made. However, there is the inevitable uncertainty about those assumptions around the resource availability, and what is different about perhaps this to the clinical strategies. We're also relying on, for the date strategy, on capital monies being available as well, and that just adds to that level of uncertainty.
Thank you very much, Paul. Okay, so I think we've got the key actions and implications identified. So we'll now move on finally to the performance and finance report. So I'll hand over to colleagues for that.
So I think that was tabled for information, David. So unless there are particular questions, I wouldn't particularly expand on that at this point.
Okay, has anybody got any particular questions? Nope. Okay, so that's the final item. Thank you very much, everybody, for this particular meeting and your contribution.